Why do some women face more barriers in breast cancer care than others? The answer isn't simple. It's intersectionality. Let's take a deeper look. Dr. Frederick Lee II, emotional intelligence practitioner, executive coach, consultant, and speaker. Previously, we talked about intersectionality, the way multiple aspects of identity overlap to shape someone's experience. Today, let's go deeper. See, intersectionality explains why Black women with breast cancer may face challenges that other women with the same diagnosis do not. It's not just about race or gender or socioeconomic status. It's about how those identities intersect to create unique forms of inequality. For example, my research showed how Black women with lower incomes often face delayed diagnosis. Not only were they more likely to encounter dismissive attitudes from providers, but financial strain limited their ability to access timely screenings and advanced treatment options. That's intersectionality at work. It's bias and poverty compounding the impact of disease. One woman shared that her doctor brushed off her concerns, telling her she was too young for breast cancer. By the time she was finally diagnosed, her cancer had progressed. Her story reflected the data. Black women are more likely to be diagnosed at younger ages and with aggressive subtypes, like triple negative breast cancer, yet their symptoms are too often dismissed. Another layer, gender expectations. Some women described pressure to stay strong for their families, even when they needed support themselves. They juggled treatment, childcare, work, all while feeling the weight of cultural expectations that discourage vulnerability. See, intersectionality shows us that we can't treat patients as one size fits all. Care must be individualized, culturally competent, and responsive to the realities of each woman's life. Healthcare systems that ignore intersectionality risk leaving women behind. But when we acknowledge it, we design solutions that work. Community-based outreach, financial navigation, culturally relevant education, and providers trained to recognize their own biases. Intersectionality isn't just a theory, it's the lived reality of millions of women. And it's our responsibility to make sure that reality is met with equity, compassion, and justice. Here's what you can do today. Number one, educate yourself. Learn about how race, gender, and class shape healthcare experiences. Number two, speak up for equity. Support policies that expand access to screenings and treatments for underserved groups. And number three, practice empathy. When listening to someone's story, ask how their different identities may be shaping what they're going through. In the comments right now, share. Have you ever experienced a time when multiple parts of your identity impacted how you were treated? Your story can help others see the power of intersectionality. I'm Dr. Frederick Lee II, and this has been your lesson in life.